TopMedTalk.
Welcome to TopMedTalk. Today's piece reflects one of the most important themes that we often return to throughout the year here on TopMedTalk: burnout. It's an important part of perioperative medicine. In some senses, patient care does start with personal care for you, the practitioner. As the main instrument in the process, it's important that you keep yourself sharp. We start with a short introduction to the subject with Mark Pinosky. With Mark Pinosky of NorthStar Anesthesia, with Desiree Chappell, Sol Aronson and Monty Mythen. This piece sets up the conversation. Whereabouts are we now in the profession of anaesthesia with provider burnout? Have a listen.
Mark Pinosky, I'm from Charleston, South Carolina. Started my career in academics at the Medical University of South Carolina, spending about 9 years in cardiac anesthesia, pediatric cardiac. Pivoted about the last 20 years and got into the private sector. And what I do now is Regional Chief Medical Officer for NorthStar Anesthesia, Vice President of Physician Services. So keeps me busy covering the East Coast. So yeah, it's fun.
Absolutely. Where are we right now in the profession of anesthesia when it comes to provider well-being?
Well, COVID really, this wasn't a new phenomenon, burnout. It's something that's been around. What we're really seeing is that COVID exposed some of the cracks that exist in that support of our physicians. And I think one of the things that's made it really fun for me is there's so many wonderful people, Amy Vinson and Florence LaCroix, all people that are academically driven, just have provided a qualitative problem and given it quantitative support, which I think is so critical. So one of the things that happened in 2018, NorthStar Anesthesia, along with our financial partner Cranemere, which is a holding company, allowed us to reinvest in our company. And we saw that it was such a critical investment in our teams to be engaging our people. So through engagement surveys, giving our team the tools and the skill sets so they can attack at the individual level. So one of the studies that just came out of the Committee for Well-Being, which I have the great fortune of being on with, just came out with an approved last year, the policy towards looking at this as an organizational problem, as a systems problem, rather than just individual. So we've invested heavily in engagement survey. One of the things that we have found, what keeps people engaged in their job, just wanting to stay, is if they feel that they are supported by our institution. So whether that's the hospital, whether it's an ASC, or whether it's NorthStar Anesthesia, we want to make sure that our people know that, number one, we're hearing them. So listen first is one of our values.
Absolutely. I experienced a similar exercise back in the UK, the hospital that I worked at. And one of the things that came out of the reports from that is you can't predict people's stressors that are leading them towards possible burnout. They might turn around and say, I'm very happy to do a long day, but there are Tuesday and Thursday, for example, it's my turn to pick the kids up. And every time I miss that target and get that added stressor, that's driving my burnout. Whereas for someone else, it's where they keep their bike safely.
And the problem is nobody's going to know it's your burnout until it starts to manifest way after you're way down the structure. So, and then we actually reward the poor behavior. Yeah. So, Monty, thanks for still working 40 hours this last 2 weeks. That's a great job. That's probably the wrong answer, right? Or what we found in this recent study that Amy Vinson was part of. If people feel like they're not engaged at work, they have a tenfold increased risk of experiencing burnout.
What are the unique stressors in the field of anesthesia that drive burnout, if you will, differentiated from other providers within the broader spectrum of healthcare?
If you really look at it, in and of itself, anesthesia is a high-stress environment, right? So we're isolated, we're behind the screen by ourselves, often don't have control either of our schedule or of what our surgical colleague is doing, what's happening on the other side of the ether screen. So there's an inherent stress. We often take over responsibility for things that we don't have control, and then too often, one of the questions is, if you want to know who the pilot in the room is, just wait, he'll tell you. So part of and I am.
And so I was saying Mark's the pilot.
So one of the things that we do a really poor job of in anesthesia compared to what we do in the aviation community is if you have an event, you want to debrief and make sure that you've had a chance to decompress from that. And what happens is we just have depersonalized the way we approach our patients often, or the way that we approach each other. So that's one of the big things with burnout. So it's depersonalization, emotional exhaustion, and then feeling like you don't really control. There's a lack of personal satisfaction.
And how do we reach beyond the screen, if you will, to use the metaphor, or objective reality, to invite those other cultures, those other people in the room to sort of own the problem and be a part of the solution? Because it's not siloed.
No, you're right. But, in your world, right, it's all about the money. Isn't it? I mean, that really what we learned is that the way that you were able to affect a lot of the changes through the perioperative continuum is to show that there's a financial gain by making these kind of change or a culture of caring, so to speak, or a culture of well-being. And the way if you look back to 1999, the Air is Human, that impacted us that who would have thought that there was a chief quality officer now? Right?
Yeah.
Or that we have an EMR that has generated all kind of problems or challenges for us. So just like that occurred, COVID has created this next event where people are just not going to tolerate this isolation, the burnout, because it's a financial burden on healthcare. It's a financial burden on they said there was something on the order of greater than $4 billion that is lost because of burnout and the loss of providers.
But there's a component, I would presume, as is an invitation for a question, recruitment and retention. The sort of provider satisfaction as a consequence of doing the right thing. And every time somebody leaves, the cost of that is a phenomenal burden.
Absolutely, right? So we're being asked to do more with less, and so that just compounds the problem when we can't retain good people. So, it's easy to live the values that we do in our organization. It's listen first, and while we're patient-centric, we're provider-focused. And what that really means is that we have leadership at the ground level that is empowered and held accountable to make sure that their team is whole, because having that peer-to-peer support structure is what really starts to bond. And so it's sometimes the low-hanging fruit, right? Mm-hmm. Are you getting the tool set to check in, right? And it's talking about, what's challenging you today? What gives you hope? What emotionally or how are you doing as a team? And then what is something that you're celebrating right now? What are some of the things that I should know about?
And again, Mark said it again, patient-centered.
Patient-centered and provider-focused.
Excellent. Thank you.
There's a lot of work being done now. Actually, anesthesia and physicians are considered to be highly resilient. But yet we're still subject to the risk of burnout. And in fact, unfortunately, the incidence of suicide or suicidal ideations is still very, very high in both anesthesia and surgeons who is really our world.
I've been involved in some panels recently. We had one actually there in our Ireland meeting that included representation from Australia, the USA, and a clinical psychologist and a broad group of people. And the key thing that seemed to come out was the first component, like classical medicine, is diagnosis precedes treatment. Now, it can't be diagnosed because it's not a disease was the conclusion, but it's a phenomenon that we have to recognize is very damaging. Therefore, we have to improve our capture of recognizing it.
Right.
How do we do that?
So through different vehicles, so both on the local level, checking in, having engagement surveys that are really geared towards making sure that you're engaged with your organization, and then identifying when there's things that are being done positively and when they're done negatively. And most importantly, our individual healthcare workers, and in this case, anesthesiologists and anesthetists, feel that not only are they being heard, but action is occurring.
Yes.
And so that's just the critical end loop to make sure that we're going to have success. I do have to shout out. So the ASA HQ hit the tab on physician well-being. It allows for not just what we're accomplishing now, but some resources there for suicide prevention, all that drug diversion stuff. So all right there. Great resource.
Worth mentioning that asahq.org is the website of the American Society of Anesthesiologists. That's asahq.org. We're going to have a listen now to Amy Vinson. As you'll hear, she's been in on the shop floor on this subject of burnout since the start. Hear how the problem has evolved and what you can do at your institution to help improve the integrity and the resilience of your workforce.
My name's Amy Vinson, a pediatrician and anesthesiologist at Boston Children's Hospital, and I have been involved in well-being work for a dozen years or so. A little while, before it was cool. Having the support of the ASA consistently over the years has been one of the most important things for gaining traction, really pushing forward culture change in medicine.
I heard you at the Stolting Conference. The Anesthesia Patient Safety Foundation has their conference every year. It's called the Stolting Conference. And I was so inspired by everything that you were talking about. And we talk about burnout. We talk about wellness. And it's like there's so much more to it than just yoga and breathing and all those things, which is a cliche and has only worsened during COVID, I think. So talk about the support from the ASA for physician well-being. They have a committee, and I never thought that there would be committees specifically around well-being.
There weren't. And so for many years, there was a working group advisory panel. It had a number of names that was under the Committee on Occupational Health. And broadly focused, people from all sorts of different backgrounds, different focuses on different areas of wellness and well-being. It reported to the Committee on Occupational Health. I got involved with that group when I was a fellow. I had done some research when I was a resident in peer support through a mentor who was running that advisory panel. When I came to that meeting, I came with a proposal of something I wanted to study. I wanted to study chairs' responses and their views on wellness and well-being and what was helpful and what was needed.
And when was this?
Oh boy, this was 2011, 2012. And it was a robust group. The conversations had were amazing and the connections made were amazing. And we would have a little booth at the meeting and just to talk about the evolution. I mean, the booth would be like way over behind the posters. I think one year we didn't even have a folding table, so we had to go find one. It was very dark. We made a sign with poster
Sharpie
board. Yes, exactly. No, we absolutely did. But it was a place where we could network and make connections. And this is before Tate Shanafelt published his data on burnout, and we were all talking about how burned out physicians were. Mm-hmm. Okay. Game changing, especially for the people already doing the work, because it gave a lot of credence to what we were doing.
Validation.
A lot of validation. Exactly. Several years later, through the advocacy of a number of the leaders within that group and support from the ASA, the Committee on Physician Wellbeing became a standing committee. This was after a year of having an ad hoc committee on physician suicide rates, which became an urgent concern when the issue of that came out in the lay press in a big way. That group sort of got folded into the Committee on Physician Wellbeing. It became a standing committee. And so we have a number of working groups looking at various things. They have tasks that they do. We have a working group on suicide and mental health, clinician mental health. We have a working group on ASA outreach that manages the kiosk that we now have. And, a number of other working groups making great systems and policy working group that has created a number of really good resources for the membership to use as a toolkit to implement a lot of the things that we're calling for in order to create a culture change in anesthesia to make it more of a culture of support. And I think we're at a moment where that's possible. At the same time, in addition to the ASA giving the imprimatur to us by codifying the group as a standing committee. At the same time, they have supported the National Academy of Medicine's Action Collaborative on Clinician Wellbeing and Resilience since it started. And I believe it was 2017 that it started. And that's both a representation support as well as a financial support to the actions. And that group of people is going to make an incredible difference in the medical landscape throughout the country.
Yeah.
So, Amy, what was the turning point? Was it the great resignation as a consequence of COVID that all of a sudden now it hit the sort of economic crisis tip point that, oh my God, we better do something because we're not okay if we don't? My second question is, what's unique about anesthesiology in the context of physician care?
I'll answer your first one first. I think it was an accelerant. I don't think COVID specifically changed medicine to the point where it created new problems. I think it exposed the cracks in the system and shone a really bright light on them. And the timing of COVID was after the National Academy of Medicine had convened 200 stakeholders from professional societies to EHR vendors to payers, regulatory bodies, all at the same table to come together from a systems and policy and organizational standpoint and address the issue of our workplace in an organized, scientific, serious manner where it wasn't blaming the clinicians. It was addressing the problems in our own house. You had that group publish a major publication, a 400-page publication, similar to Air is Human or Crossing the Quality Chasm. That was 6 months before COVID hit. And when COVID hit, people started talking about mental health in a way that they previously hadn't felt comfortable doing. But I think there was such a mandate societally because of how profound the stressors were, how profound the experiences were, that you couldn't ignore it anymore. You couldn't sweep it under the rug anymore. There were a couple high-profile suicides as well. Mm-hmm. And as tragic as they were, I think it opened a lot of people's eyes to talking about this in a more meaningful way. And when you have that happening at the same time, when you have that momentum from this really broad group of serious people wanting to make a change in something, and then having something like the pandemic happen, where now we are seeing in broad daylight the issues with our system, and we're talking about them in a way we never have before. And at the same time, we've entered this creative mindset where in our day-to-day lives, we're doing things very differently. We're shopping differently. We're working differently. We're interacting with each other differently. So you have this creative mindset, you have this momentum, and you have this public discourse all happening at the same time. Initially, I think the Academy was worried that COVID would stop their efforts and all the focus would then be on the medical side of things. But what we saw was completely different. It was a bolstering of those efforts and a call to action that has been highly supported. And now one of the co-chairs of that collaborative is the U.S. Surgeon General, Vivek Murthy. And when releases happen, press releases or initiatives or reports or plans are released, it's actually coordinated with Health and Human Services. And so you have some very serious people at the table approaching this problem from a very pragmatic and systematic method. I'm incredibly hopeful that we're going to make meaningful changes to improve our workplaces, because at the end of the day, we want to take good care of our patients. We want to have that interaction with our patients. That's what gives us resilience and gives us meaning in our job. There's so much stuff that gets in the way of that I think leads to burnout, worsens burnout, those inefficiencies in the system, regulatory burden and documentation burden and pajama time, which is, interacting with the EHR, your work email when you shouldn't be at work.
I was like, what is pajama time?
Pajama time. It's one of my favorite terms. I've just learned it recently, and I'm using it as much as possible.
I totally get it. Like, wow.
You're sitting in your pajamas charting.
Yeah.
It's some issues are bigger issues in other specialties. My best friend is a family practice doc. Pajama time is a real thing for them. I've seen pictures of docs, charting on a stool while their kid's in the bathtub.
Oh, yeah.
And that's not okay.
It's not okay.
And it's not necessary. We can make it better.
Maybe it's not charting. Maybe it's like answering the 1,000 emails that while they were in clinic, piled up for them. And that's work still.
It is work. And
more work, actually.
And there's a very gendered component to that specific one of answering messages, again, especially in primary care.
So, Amy, obviously suicide is such a dramatic, horrible metric of bad. How are we measuring that today? How are we beginning to, sense the predictors of bad, if you will, along the journey?
The fact of the matter is it can happen to the best, most professional of us. There's only so far you can push someone before they start disengaging as a mechanism of survival, right? You asked me before, what makes anesthesia so special? What's interesting about that is that I didn't get into well-being work until I made the transition from pediatric residency to anesthesia residency.
Oh.
Go on.
And
that's what I was actually going to ask you a little bit about.
Please continue.
It's the isolation.
Yes.
And it's not just the isolation. You can have a bad outcome and absolutely nobody knows. And you're all alone, and you've physically been involved in that. But beyond that, we have this mentality that we can achieve perfection.
Yeah.
And that we can control everything. We love control. I mean, ask our spouses, right?
Yeah.
We love control. We love, knowing what plan A, B, C, D, E, F is.
And then you give her a drug, and you know what's going to happen, and you know when it's going to happen, and I'm going to do this, and ultimate control of the situation.
And then something bad happens.
Yeah.
And it may be something that you truly could not have had any control over. Maybe a trocar goes in the aorta. You couldn't have seen that coming, right? But the amazing thing I see anesthesiologists do, I saw someone have that very situation, and it was for a laparoscopic outpatient procedure. They had like a 22 or a 20 in the hand. It was fine.
Yeah.
Totally, healthy person. Yeah. The first thing they said to me is, I should have had a 16 in them.
No. Oh,
and you're like,
it was a lap hernia. No,
you shouldn't have.
Yeah.
There's no way you can take responsibility for that. And so I think, part of our personalities are kind of, we're a little on the OCD spectrum. We're a little on the anxiety spectrum. And it makes us do a very good job at anesthesia.
Yeah.
But it also sets us up to take a really outsized responsibility for outcomes.
Yeah.
And then you add the isolation to that, and it's a setup for really truly enhanced isolation and enhanced disengagement.
One of the things I found when I first started in anesthesia, so I'm a practicing CRNA myself, and when I was first out of training, I don't even know if I was maybe still in, and I came home and I was talking to my spouse, and actually my parents were there, and I was just like, oh God, it was a horrible day. I just had a terrible day. I had, whatever happened. And my dad was like, well, no one died, did they? And I was like, if that's measure of a bad day for me, that's like a really, really bad day. And it's still been really hard to communicate like what is a rough day for you and for people to really understand. And it's like people don't really get it if you're not doing it.
But anesthesia, it's almost cloaked in mystery. I think
the isolation piece of this.
Exactly, but I think we perpetuate it culturally in anesthesia.
It is, and we know what we do, but we don't talk to each other because we're isolated,
right?
And we don't have that natural support opportunity, and we're measured by metrics of efficiency. Get that case started on time.
I mean, it's funny. We were talking about Twitter earlier. I tweeted out about a week and a half ago something along the lines of, what if the better metric wasn't on-time first case starts, but what if the better metric of patient quality of care was appropriate delayed starts?
Oh, my gosh. You just flipped it on its head.
Right? Because... Yes, we need to improve efficiency. We need to optimize things for throughput and patient experience and patient expectations, but we also need to leave room in there for the unexpected, for the last minute questions, for
those things that we shouldn't have to push on and maybe overlook,
right?
Just because we are so under such production pressure,
exactly,
and efficiency. Yeah, for sure. Let's talk about signs and symptoms of burnout and how do we know if we're burned out ourselves?
One of the most important things about understanding burnout is understanding what your early warning signs are, because it's a spectrum. So the Maslow Burnout Inventory was developed in around 1980, 1981. Occupational burnout was described in 1974 for the first time. Since 1980, that inventory has been well validated in pretty much every job where you have a human caring for another human that requires occasional self-sacrifice or self-effacement. It's broken up into 3 domains: emotional exhaustion, depersonalization or cynicism, and low sense of personal accomplishment. Now, depersonalization we do as a function of our job often. We take care of the lap chole in room 11, or, you depersonalize. If you don't think we depersonalize, try this trick. You're in the OR, and the surgeon's like, how's the blood pressure? And you say, oh, Mary's blood pressure is great. It's whatever. Yeah. If you refer to the patient by their first name while they're anesthetized, it freaks everybody out. It
Never
really
tried
makes
that
people.
before.
I don't do it every day because it makes people really uncomfortable.
Right.
But we depersonalize as a function of our job. It's just naturally what we do, and that's okay. It allows us to focus on what we need to focus on and keep things safe. It becomes an issue when we start using it as a coping mechanism. Some people experience emotional exhaustion as their first symptom. For me, I'm typically not a sarcastic person. When I start getting burned out, I start making sarcastic jokes.
Interesting.
And the thing about that, being an early warning sign, is nobody else is going to notice it. They'll laugh because I made a joke and it was funny. But for me, I'm like, uh-oh,
man,
that's not good.
Yeah.
And it has nothing to do with the patient. I mean, it's not an unprofessional joke. It's just I was sarcastic about something. And at that point, I realized, okay, this is a very early warning sign. I need to do something intentional to right this ship. And that may be planning a vacation that's 3 months off.
Yeah.
Intentionally saying, I'm going to treat myself to something. Or at least I'm going to be aware of it. The head in the sands approach when you're getting burned out is dangerous. And I think so many people aren't self-aware enough that they get way down the burnout cascade to frank dysfunction before, they're displaying all 3 domains.
Right.
At the same time. In our survey a couple of years ago, we found that of the respondents, 14% of people reached threshold criteria in all 3 domains at the same time. So they had full burnout syndrome.
Gosh.
What do you do about so many people being burned out?
Yeah.
Okay. Depending on who you talk to, the percentage of responsibility for fixing this falls in a minority on the individual. Okay? The data shows that physicians, advanced practice nurses, clinicians are highly resilient people. They're more resilient than the average person. So the solution is not resilience training. You should be as resilient as possible, and it can be helpful to engage in resilience training. It can be very helpful to engage in mindfulness-based stress reduction or mindfulness training or meditation or yoga or fitness or nutrition or all these aspects of wellness. But we need to be talking about well-being. And the difference between those two words is not just semantics, it's meaningful. Well-being encompasses the environment in which you are working, the environment that you are in and how that impacts you. So now the onus shifts from being squarely on the individual. What is wrong with that doctor? What is wrong with that nurse? Why are they burned out? What's wrong with me? To what support do they need? What are they missing? And when we looked at the data, and we did the Maslow burnout inventory, and we did a multivariate regression analysis with the other 13 practice factor and demographic questions that we asked, we found that the question, how supported do you feel in your work life, was far and away way more impactful than any other thing that we asked. I mean, there were impactful things, staffing shortages, working more hours, being in the LGBT community that put you at risk for burnout. But their odds ratios were like 2.
Oh.
If you said you had little to no support in your work life, your odds ratio of being at high risk for burnout was 6.7, which is massive.
Yeah.
And your odds ratio of having the full burnout syndrome was 10. That's when you see the chart, it's just off the chart. So the question is, what makes you feel supported in the workplace?
Exactly.
Exactly. And that's where you need to engage your group. And every group is different. So one of my favorite things is to ask, what makes you feel supported in the workplace? What makes you feel not supported in the workplace? What's something we can change now that would improve your life? What's something that's going to take more time, but we should look into fixing? And asking those 4 questions and figuring out, okay, what is it? Is it faculty development that you need, resources for childcare, flexibility in your work hours?
So, Amy, anesthesiology is a highly compensated specialty. We address the question of how do we support our working environment with the answer, we get paid more, or we demand to get paid more.
But if you look at the trends of the new generation coming up, the new generation of medical student grads and residency grads, they are saying more and more that they would rather work fewer hours and get paid less. That's what they are saying.
Okay.
And in general, across other fields, not just medicine, this next generation coming up would rather work less for less money. And so throwing money at the problem isn't solely going to fix it. Now, that adds a whole new degree of issue when we're looking at a clinician shortage that we're experiencing right now.
We have
that's only going to get worse.
Exactly,
right?
Exactly.
And so we have got to start creating cultures of support in our organizations that meet people where they need to be met and address the diversity of circumstances that they come with. Meaning, for some people, more money is what they need and they'll work more hours and that's fine and that's going to be gratifying for them. For other people, they need to work fewer hours or more flexible hours and get paid less, and there's a trade-off there. For other people, they need support in the form of, like I said, faculty development or something like that. And it's a much more tailored approach, but I think that's what we're going to need, A, if we want to sustain the workforce and recruit and retain, but B, if we're going to attract and retain a diverse workforce. It's a huge challenge.
It's a very huge challenge because it makes perfect sense. It's just not the way we've done things.
It's not the way we've done things, but the way we've done things was based on a rubric of having one FTE at work who could work late And that was fine, and there was going to be no repercussions to them working late. And they had one FTE at home that took care of the kids and the house and everything there. And that's how it was for decades. And that's not even close to how it is. Most physician households are 2-income households. There are very different stressors. That model doesn't really exist that frequently anymore, but it's still how we staff hospitals. And so it's creating quite a bit of work-home conflict that are experienced in a variety of ways. And you know, I think the work that groups like Women in Anesthesia are doing and the diversity, equity, inclusion work, investigating, you know, the ad hoc committee on systemic life imbalances that the ASA convened last year to look at this and say, how are people actually experiencing these things differently? What do we need to do to increase the support? We've got to think about staffing differently. At the same time, there's only so much you can do with so many train cars, right?
Yeah.
There's only so many people. How do we stretch that further? Well, one of the ways, and going back to the National Academy's work, is to make things more efficient. To remove a lot of this regulatory burden, to remove a lot of this documentation burden that makes the process of doing our job less efficient. So now you could have a physician or a nurse anesthetist or what have you being able to do more because the requirements are more streamlined, if that makes sense.
Yeah.
In the past, we would talk about investing in well-being,
Right.
and we would talk about the return on investment and the financial case for investing in well-being. And that's all well and good. There's some really interesting economic models, and it makes financial sense to keep people where they are by supporting them in the way that they need. It usually is less of an investment than replacing them. But I think now we're in a very different situation where it's beyond a return on investment discussion, and in many instances in certain hospital organizations, it may actually become an issue of solvency.
Wow. Yeah.
So I think that's what we're going to see. I think we're going to see the strain on the workforce worsen in the next year. I think we're going to see more physical illness in the workforce, which may accelerate things. That's my concern. And so I think organizations need to double down on the actual health of their workforce and investing in that right now.
Yeah.
I think that will pay in the long term.
Yeah.
We've got to get through this section.
Yeah. Well, that's what I was going to ask when you talked about, you know, the policy level solutions and some of the things that we're working on from a, systemic level. Organizational, a lot of us may actually have some influence in kind of the organizational level, either with the facility or the groups and things like that. What are some things that we can do today to really start trying, to get to a better place and improve well-being?
I think the first thing that needs to happen is enhancement of psychological safety in an organization, because you've got to create a team between leadership and those who are led. Yeah. And there needs to be two-way communication between those groups with no fear of reprisal, repercussion. And a lot of times, for some people, that's going to mean an anonymous comment box. That, and that's how we've organized
Ted Lasso. That's what Ted Lasso did.
Well, there you go. I mean, I can't beat Ted Lasso.
No, but I mean, it was, people will put...
They will put anything. But what he did and what's required is accountability.
Absolutely.
And responsiveness. And so you can have an anonymous comment box, but if nobody addresses those comments and takes responsibility for improving things based on those comments, there's no trust.
Right.
And people will stop using the box because it's useless. Right. So that's, I think, building in psychological safety and improving the relationship between leaders and those they lead at whatever level we're talking about is the first step to finding out what it is that's going to make people feel more supported in the workplace.
Yeah, that's great.
This is a first step of a complex, long,
very complex,
continuous conversation. I would guess that we will have Amy back.
Absolutely, 100%. Yeah.
Anytime.
And you've come a long way from the booth without a folding table.
Of course, both of these conversations are available unedited and in full. You can find the links in the show notes, along with a few other pieces on this subject. It's something we often return to here on TopMedTalk, where it's important to take care of yourself as well as your patients. Thanks for downloading TopMedTalk. Don't forget, of course, you can subscribe. We're on YouTube, we're on LinkedIn, Facebook, we're on most of the social media sites. Just pop in TopMedTalk and we're sure to pop up. And if you want to connect with us more deeply, we are, of course, the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that, and you can do so by going to ebpom.org.